Dear students, welcome back. In the previous session, we have discussed about deviations from optimal alignment on the lateral view. Okay, in this session, we are going to discuss about deviations from optimal alignment, anterior and posterior views. So, before discussing about this deviation, we should know in the anterior and posterior views where the LOG actually falls. Okay, in both anterior and posterior views, the LOG bisects the body into symmetrical halves. So here the body is divided into two symmetrical halves. The head is straight with no tilting or rotation is evident here, we can see here, and the face is bisected into two equal halves. Okay, the eyes, clavicles, shoulders should be level, parallel to the ground. In the posterior view, the inferior angles of the scapula should be parallel to the equidistant from the LOG. The waist angles and the gluteal folds should be equal. Here you can find the gluteal folds that should be equal. Okay, and the ASIS, anterior superior iliac spines, and posterior superior iliac spines, okay, should lie on a line parallel to the ground, as well as being equidistant from the LOG. From the LOG, the ASIS and PSIS should be in equal distance. So the joint axis of hip, knee and ankle are equidistant from LOG, and the gravitational line transects the central portion of the vertebral bodies. Transects the central portion of the vertebral bodies. When postural alignment is optimal, little or no muscle activity is required to maintain medial or lateral stability. The gravitational torques acting on one side of the body are opposed by equal torques acting on the other sides of the body. So this is the thing happened in the alignment when we look for anterior and posterior views. Okay, and now we'll move on to the deviations from the optimal alignment. The first one we can see is the foot and toes. What happens in the foot and toes here? And also there may be some asymmetry in the knee as well as in the vertebral column also. So any asymmetry of body segments caused either by movement of body segment or by unilateral postural deviation will disturb optimal muscular and ligamentous balance. Symmetrical postural deviations such as bilateral genu valgum that disturb the optimal vertical alignment of the body segments causes an abnormal distribution of weight bearing or compressive forces on one side of the joint and increased tensile forces on the other side. The increased gravitational torques that may occur require increased muscular activity and cause ligamentous stress in the case of knocked knee. Now first we will see foot and toes. So already we have discussed about this flat foot and pes cavus also, that is high arched foot. Now, so what happens, how this flat foot and pes cavus are related to the posture, now we will see. In evaluation of standing posture from the anterior posterior aspect should include a careful evaluation of the feet. Normally, the plumb line should lie equidistant from the malleoli. Normally, the plumb line falls equidistant from the malleoli. Okay. And normally, this plumb line, which is equidistant from the malleoli, and the malleoli should be appear to be equal in size and which is directly opposite from one another. When one malleolus appears more prominent or lower than the other and calcaneal eversion is present, it is possible that a common foot problem known as pes planus. Okay, so this is the flat foot, pes planus. Here you can find the calcaneal eversion also here. Yes, and here you can find the decreased arch. Okay. So, calcaneal eversion of 5 degrees to 10 degrees is normal in toddlers, but by 7 years of age, no calcaneal eversion should be present. Flat foot, which is characterized by reduced or absent medial arch, may be either rigid or flexible. A rigid flat foot is structural deformity that may be hereditary. In the rigid flat foot, the medial longitudinal arch is absent in weight bearing, toe standing, and the normal weight bearing situations. In the flexible flat foot, the arch is reduced during normal weight bearing situation but reappears during toe standing on non-weight bearing. Okay. So, there is a test, we can some radiological evidence we can find with that of whether the foot is a normal foot or a flat foot by knowing the fess line. Okay, so the fess line, here you can find the fess line. In the normal foot, the medial malleolus, okay, the tuberosity of the navicular bone and the head of the metatarsals lie in a straight line, which is called as fess line. So, if what happens, if the navicular bone is depressed, it will lie below the fess line and maybe even rest on the floor in severe case of flat foot. So flat foot results in a relatively overmobile foot that may require muscular contraction to support the osteoligamentous arch during standing. So by knowing the fess line, we can identify whether the foot is normal foot or flat foot also. Okay. Yes. Next we'll move on to the pes cavus. The medial longitudinal arch of the foot, instead of being low, it may be usually high. Okay, high arch is called pes cavus. Pes cavus is more stable position of the foot than in pes planus. However, the weight in pes cavus is borne on the lateral borders of the foot and the lateral ligaments, and the peroneus longus muscle may be stretched. Okay, in walking, the cavus foot is unstable to adapt to the supporting surface because the subtalar and transverse tarsal joints become locked, that is supinated position. Therefore, the cavus foot is not a good shock absorber. So these are the things we can find in the a deviation of the foot. And the toes we can consider here also the hammer toe and claw toe and the hallux valgus. So the hallux valgus, that is increase in the medial angulation of the first metatarsophalangeal joint leads to hallux valgus. Okay, so these are the deviations we can see in the foot and toes. Now we will move on to the knee. Okay, so that one is genu valgum. So in genu valgum, the mechanical axis of the lower extremities are displaced laterally. The anatomic axis of femur and tibia are deviated from vertical alignment. So the gravitational moments which tend to produce motion of the proximal femur laterally and the motion of the proximal tibia medially. This is the thing which is going to happen and medially or greater than normal. As a result of increased torque acting around the knee, the medial knee joint structures are subjected to tensile, okay, whereas or tensile or distraction stress, and the lateral position of the femurs are subjected to compressive stress. This will have the tensile stresses and this will have on the lateral aspect will have compressive stress. These abnormal stresses may cause atrophic changes in the medial meniscus and hypertrophic changes in the lateral meniscus. The gravitational torque acting on the foot in genu valgum tends to produce pronation of the foot. Okay, which accompanying stress on the medial longitudinal arch and abnormal weight bearing on the posterior medial aspect of the calcaneus we can see. Okay, in the case of this thing, that is B, this is the condition of genu varum, that is called as bow leg. In this condition, what happened? The lateral aspect of the knee complex is subjected to tensile stress and the medial aspect of the knee complex is subjected to compressive stresses. So these are the deviations we can see on the anterior view at the knee level. Okay, so we can see another important variation we can see on the posterior aspect, that is called as scoliosis. This is lateral deviation of the vertebral column is called as scoliosis. This scoliosis we can discuss in a separate section. Thank you.